Thank you so much for all of you for joining this session, Service Experience, Interlinking Supply and Demand for Immunization Services. My name is Kate Bagshaw, and I'm a technical officer with John Snow Inc.
And I'm Francine Ganter Restrepo. I work in demand and behavioral sciences at the World Health Organization. So we're going to start with unpacking this term, demand. It's a term you've likely heard before, as it's gained a lot of attention recently, notably in the Immunization Agenda 2030. It's a concept that's woven throughout. Not only is it a strategic priority in and of its own right, but it's implicated across many other strategic priorities and all of the core principles. With this presentation, we're going to do a deep dive into what demand means, and specifically what it means for you in this audience in supply. So what do we mean when we talk about demand? We're not talking about demand in the classic economic sense of supply and demand. We're talking about demand for immunization services. So we've differentiated it here with a capital D to emphasize that. Demand for immunization is individuals understanding the value of vaccines, actively seeking and supporting immunization as both their right and their responsibility. It encompasses the interactions between people, system structures, including supply, and the system dynamics. Demand is complex and it's context dependent. It's shaped by a range of social, structural, and environmental factors. So what are the factors that shape demand? A working group tasked with measuring the behavioral and social drivers of vaccination, that's the BESD working group, has determined 4 key domains that shape demand and uptake. These are what people think and feel about vaccination, the social processes that shape vaccination and other health-seeking behavior, motivation to get vaccinated, as well as all the practical factors included in this. Under these domains, you can see some suggestions for what each box could contain. Under practical factors, what we're largely going to focus on today, we have the example of affordability, accessibility, and quality of services. But let's explore this a little more deeply using a separate and complementary framework. The Unicef caregiver journey is another way of looking at what shapes demand and uptake for vaccination. This journey encompasses all the same elements of the BES framework, but with a real-world, people-centered focus. It shows the different stages, or the obstacles, if you will, that a person will have to overcome on their journey to immunization. Starting with knowing about vaccines, when and where to get them, wanting to get them, and all the preparation and logistical barriers on the road ahead, such as permission from employers or a member of the household to go, arranging your travel or childcare for other children you may have, and all the cost implications of that too. It also includes what happens once at the clinic and after you leave. So any follow-up a clinic might send, reminders, prompts, to ensure that someone returns for the next vaccines. This journey illustrates how motivation is a critical factor throughout the entire journey. It needs to be present with you all the time if you want to complete your full schedule of vaccines. Further, this framework illustrates the impact that each vaccination journey will have on the next. A caregiver has to complete this journey many times over on the full road to immunization. Each journey is an experience. It forms our attitudes about vaccination and about the healthcare system at large. These are the spillover effects of quality of services. If we take a life course approach to immunization, the journey has even greater significance. Research demonstrates that experiences with childhood immunization impact our decisions around adult vaccination later on. A positive experience is likely to result in positive thinking about immunization and interactions with the health system more broadly, and it'll encourage further engagement. Whereas a negative experience can increase the likelihood of dropouts and impact how an individual chooses to interact or not with the health system more broadly. So it's important to get this journey right if we want to achieve full coverage or universal healthcare for that matter. So how can we better curate more positive quality service experiences? What are those components that we have to get right? And what is the work that needs to happen behind the scenes to deliver on positive service experiences? I'm going to hand over to my colleague, Kate, who will talk you through that.
Thanks, Francine. So as Francine highlighted, we know from both the BES framework and the caregiver journey that service experience is not just about the point of interaction between the health worker and the client during an immunization session. There are many things outside of that point of interaction that can affect service experience, and these shape the journey to immunization as well. The figure on this slide figurizes the key components or levers at various levels of the health system, from the national down to the community level, that can influence the immunization service experience. As part of work carried out by the Demand Hub Service Experience Workstream, these components were identified through a series of key informant interviews at the global and regional levels, as well as insight gathering exercises in 4 countries that aimed at trying to inform a new direction in people-centered immunization service experience. These components include things like policies and guidelines that influence the organization and delivery of immunization services, and the leadership and financing to support the implementation thereof. A key component of ensuring a positive service experience is the empowerment of health workers through pre-service or in-service training, supportive supervision, or communities of practice to deliver quality care and engage with communities around immunization with confidence. Also important is the way in which fixed, outreach, and mobile immunization sessions are organized and how often, how immunization is provided in different settings, whether that be in urban or rural areas or public or private facilities, and whether they're delivered through an integrated package of services. Something as simple as the health facility environment, that is, the look and feel or the cleanliness, can affect how somebody experiences the care. And service experience is also influenced by how and to what extent community actors and stakeholders are engaged in the design and delivery of services, and the ways in which their needs are shared and incorporated into decision making. And finally, a key component is understanding how both the healthcare worker and the client or caregiver interpret and perceive the experience that they've had. All of these components need to be taken into consideration when thinking through how to create a more positive, people-centered immunization service experience. So then the question is, how does this all relate to supply? If you look at the visual, you can see that the root of our flower is resource availability and logistics. The immunization service experience depends on the availability and access to supply of vaccines and commodities. As one of our country key informants noted during an interview, all of the service experience components included in this figure only make sense if vaccines and a functional cold chain exist. If a client goes to a clinic and is turned away due to lack of vaccine, this can result in a negative service experience and a potential decrease in demand. This client may not make a return journey for the next vaccine on the schedule. Supply matters for demand. So then why should demand matter to you? To answer this, we're first going to take a closer look as to how service experience shapes behavior. If we move on to the next slide, we'll see a busy slide, but much like the Unicef caregiver journey we discussed earlier, it's important to consider the health worker journey when thinking about immunization service experience. So this slide is a visual depiction of the day in the life of Anissa, an urban health worker for MCH services. She's responsible for carrying out daily vaccination sessions from Monday to Thursday in a facility that is understaffed. On top of that, as you can see, sure, she has a lot going on in her day. She's also a wife and she's a mother and has responsibilities there. So all of these responsibilities combined influence how Anissa will be able to engage with her clients and in turn, how they both experience care. But I really want to focus on 2 parts of Anissa's journey moving forward. We're circling them here. It's the broken fridge and the district hospital. So we can move toward the next slide. We'll deep dive into this. These 2 parts of her journey affect her own experience as a health worker, but they can have longer term effects on demand for an uptake of immunization services and health services overall. As you can see, Anissa's facility has a broken fridge. So this means that every day before arriving at the health facility, she must first go to the district hospital to receive the vaccines she needs for immunization sessions. Some days she might be late to her facility because she has to wait longer than expected at the district hospital to collect the vaccines. Maybe she gets stuck in traffic. And of course, at the end of the day, because she doesn't have a safe storage option at her facility, she has to bring the vaccines back to the district hospital. Collecting and carrying the vaccines every day poses risks to the cold chain. In addition, on days where she underestimates the number of vaccines needed or where more clients show up than expected, she may have to turn clients away. And because they occur Monday through Thursday, she has to do this journey 4 times a week. Over time, if clients are turned away or if Anissa is consistently late opening up the facility, They may start to lose trust in Anissa as a health worker and question the reliability of services provided at the health facility. As a result of this, there could be the demand for immunization, that is the acceptance and uptake of vaccines, that could decrease and affect immunization coverage and equity in our health catchment area. I want to move forward to the next slide, which sort of shows how what is happening with Anissa, the health worker, may play out with a caregiver, this young mother, Ina. So this figure here represents Ina's journey to immunization as a caregiver. If we start at the top left, Ina is in her community and her neighbor encourages her to take her son to get vaccinated at the district clinic. She goes and she gets permission from her husband to take the day off of work so she can bring her son to the clinic for immunization, and he agrees. Because it's too far to walk, they have to make sure that they have enough money to pay for a round trip bus ticket to go into town. Now, as we see, upon arriving at the clinic, she's asked to wait for 3 hours. And as the time passes and the hours pass, eventually the clinic nurse comes to her with bad news. They just ran out of vaccine. The nurse tells her that she should plan to return in 2 weeks from now when they hope to have more. So when Ina returns home, her husband is angry. She was late. The bus was late, so she's late to come home with her son. He didn't receive the vaccination. They spent money for the bus fare and didn't get vaccinated, and she wasn't able to earn money that day because she wasn't at work. So with this experience, Ina may not return to the clinic. If we move forward to the next slide, we can talk about what a positive experience for Ina might look like instead. In this journey, we see that Ina arrives at the clinic and she is met with prompt service and shown to the vaccination station in a private setting by a friendly nurse. The vaccinators show her how to hold her baby while they give the injections. They explain the benefits of these vaccines, and they let her know when to next come in for the next vaccination. When she gets home, her husband's pleased. She and the baby are home. The baby's vaccinated. They talk about the next session and the vaccination schedule, and they agree on the importance of attending. Ina will, in this case, likely return to the clinic. If we link this back to Anissa, our health worker, we can see how simple measures can lead to more positive experiences and outcomes for Ina and her son, as well as Anissa, the health worker. When vaccines are available at the facility and Anissa doesn't have to travel to and from the district hospital 4 days a week, she has more of a chance to arrive at the health facility on time. Arriving on time means she may be able to better manage patient flow. She'll have more time with clients to explain the benefits of the vaccine and the vaccine schedule, as well as answer any questions that may come up in the session itself. And then, of course, Ina's son, gets vaccinated. So we can see how the challenges that Anissa faces impact Ina and how that impacts Ina's experience of vaccination and future engagement with the clinic overall. Their experiences are intertwined. They're two sides of the same coin, the delivery of services and the recipient of services. So moving forward, we want to reiterate that there's no element of the service experience that's isolated. Each component links to the others. Each decision has an impact on the other components and impacts the overall journey, that is the delivery and experience of care. This is why we must place a strong emphasis on the importance of quality services, on resource planning, and the connections necessary between providers and communities to deliver quality services. When well planned to meet the end user need, these closely interconnected links form a virtuous cycle or a chain of events that can lead to better health overall. In acknowledging their interdependency between supply and demand, or the delivery and experience of service, how then can we better construct these links to strengthen this cycle? How can one, that is demand, better serve the other, supply? I'm going to hand it back over to Francine to talk about this a little more.
Thank you, Kate, for that. So to reiterate your question, how can one, that is demand, better serve the other, that is supply? We're going to answer that question by drawing from another example. We're going to explore the case study of Shela Borokche in Ethiopia. It's a sizable health facility in a district with a population of just under 400,000. Shela Borokche was in a routine of using a top-down planning process led by the health facility staff exclusively. Planning for essential health services, including immunization, had followed a method of setting new targets on the previous year's performance indicators and data. It also used outdated census data from 15 years prior. In short, children were missing out on essential vaccines because of this poor quality data and inadequate resources. So in 2017, Sheila Barokshi was among several health facilities across Ethiopia to initiate a REDQI strategy. That is the Reaching Every District Using Quality Improvement initiative supported by JSI. The strategy promotes a bottom-up approach to quality planning and applying the REDQI tools to real local problems. By engaging non-traditional players in the planning from the community, such as local leaders, prominent social groups, and other influential community members, Sheila Barokshi was able to better leverage local knowledge in the health service planning. So for example, communities knew better than anyone their localities, from selecting the best sites for immunization services to local leaders who knew the whereabouts of their people with absolute precision. This knowledge became invaluable for developing local solutions. The community leaders conducted headcounts of children that provided firsthand, verifiable, name-based data about the target population. This was a much needed improvement on the 15-year-old census data. This revealed that the health facility hadn't been providing sufficient outreach services to reach every child. And the decision was taken to plan for expanded routine immunization activities with a new micro plan. The output of the REDQI strategy was the co-developed micro plan that leveraged all of this local knowledge in the tangible ways that I've just explained. And this new approach did lead to tangible results as well for the health facility. It included added funding. The microplan became an advocacy tool for critical resources and within months resulted in a 21% funding increase. This translated into good results for demand as well, as more outreach sites were added and more monthly immunization sessions occurred and more outreach sessions were added to respond to community needs. This slide illustrates what Sheila Barokshi achieved and highlights the results that could be used when making supply decisions in the future. The community engagement and microplanning presents an opportunity to go one step further still, something that wasn't done in Ethiopia, but there's potential there to do so. To use consumption-based forecasting, that is numbers from the microplanning and specifically the community estimates, to influence supply estimates and ensure regular, steady supply of necessary resources. Imagine what that could mean for influencing supply decisions. So back to your question, Kate, how can one better serve the other? How could demand data and service planning processes or indicators better support supply decisions? And how can we better serve one another by recognizing that interdependency to strengthen this virtuous cycle? So we've discussed in this presentation how demand is variable and depends on many things. We need to measure what those are, what the social and behavioral drivers of immunization are, to better understand them and to better plan and shape services that encourage demand and uptake of vaccines. Supply decisions, in turn, specifically the quantity of stock sent to a facility, are made largely based on target population and what is available at the district level. However, monitoring and drawing upon demand and service experience data can help us to better plan vaccine stock needs. We also see how community mapping, so engaging communities and mapping exercises, as was done in Sheila Barokshi, we can identify a more accurate target population and identify delivery approaches that are responsive to the community needs. However, those numbers aren't considered official, so they often don't get used for official supply calculations. This is very local data that too often doesn't get fed into higher levels of decision making, and that results in a gap for useful information that's underutilized. The next step from the community participation, as I touched on in my last slide, in the microplanning would be to incorporate the microplanning results into planning at every level above the health facility too. And incorporating this data can render more accurate supply estimates across the district. Another intervention that we use a lot in our work in demand is community engagement and participation. And we see how the community engagement and participation in the planning of immunization services can contribute to establishing trust with communities and building confidence in the health system. And together with communities, we can tailor programs to meet the local need. This also results in more resilient services, something that we're coming to see the importance of, especially right now. Engaging communities in planning on the supply side can also allow for better provision of the stock without over or under estimating what the stock needed is to ensure that all children are reached and we minimize on waste. Finally, I want to emphasize that acknowledging this interlinkage between supply and demand is a huge leap. A path forward could be easier than you think. The key components of this should include active and intentional engagement with a diverse range of stakeholders, including the recipients of immunization and other essential health services. Another key component would be using or developing a common tool, such as a microplan or another short document that outlines the following 3 essential things: the key service improvement priorities, the targets, and the responsibilities for achieving those. And this document should be used to ensure that each side, that is providers and recipients, people on supply and demand side, are jointly holding one another accountable to meet those targets and track the key deliverables. I want to thank you very much for listening. We appreciate your interest in this subject. Please be sure to engage with the Demand Hub Service Experience website, under which much of this work is done. And do feel free to contact either myself or Kate should you have further questions or want to engage in further discussion. Thank you.